Hello and welcome to my channel of Pain Academy. The name of this channel is Learn Pain Management. Today's topic is Pathophysiology of Pain. Hi, I'm Dr. Rajiv Varshe. I'm a pain management consultant. I work with Apollo Hospital Ahmedabad and I have my private consulting at Gandhinagar, Gujarat. I am pain consultant to His Excellency Governor of Gujarat and a visiting professor to Parul University, Vadodara, Gujarat. Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Right? So there may be actual damage or there may be just a potential tissue damage. Pain serves the purpose to prevent tissue damage and protect the body while it's healing. But when pain becomes maladaptive and stays back after serving purpose, it becomes disease itself and then it needs treatment. The painful stimuli are detected by nociceptors. What are they? They are the free nerve endings located in the tissues and organs. There are two types of nociceptor, high threshold mechanoceptor and polynodal nociceptor. Now, high threshold mechanoceptors which stimulate small myelinated A delta fiber and transmit a well localized, sharpened pricking sensation that lasts as long as the stimulus. Polymodal nociceptors that stimulate small, unmyelinated, slowly conducting C fibers, as well as responding to mechanical stimuli that are activated by thermal and chemical stimuli. And these are the chemicals which are involved in that. Okay. Now, the conduction of these impulses is done by the voltage-gated sodium channels, which mediate conduction along primary efferents. NAV 1.7 and NAV 1.8, these channels seem to have a specific role in pain modulation. Nociceptors also have voltage-gated calcium channels, which are found on the presynaptic membrane and are involved in neurotransmitter release at the dorsal horn. These are modulated by alpha-2 delta compounds such as gabapentin and pregabalin. That's why they are used as first-line treatments in pain. Okay. Now, pain is transmitted by primary efferents, which have their cell bodies in the dorsal root ganglion. They terminate in the dorsal horn of the spinal cord. The dorsal horn cells are divided into specific regions, so laminae called Rexed laminae, with lamina 1 being the most superficial. A delta fibers are fast conducting and transmit the sharp pain on initial stimulation. They terminate mainly in the lamina 1, but also send some fibers to lamina 5, where they synapse with the second order neurons. They contain the neurotransmitter L-glutamate. C fibers are unmyelinated, slow conducting fibers which transmit a less well localized, persistent aching pain that lasts after the initial stimulus is gone. They terminate in lamina 2 of the dorsal horn. A beta fibers conduct low intensity mechanical stimuli which convey touch and pain. However, in chronic pain states, they are involved in the transmission. They terminate deeper in the dorsal horn in lamina 3 and 6. Primary sensory afferents terminate in the spinal cord where they synapse with the cells of the dorsal horn. Nociceptive specific neurons are located mainly in the lamina 1 and 2, but also in lamina 5 and respond only to noxious inputs under normal conditions. There are a number of different cells involved in relay of painful stimuli, including nociceptive specific cells and wide dynamic range neurons, WDR. Now, wide dynamic range neurons are located mainly in the lamina 5, but also in 3 and 4 to a lesser extent, where they respond to stimuli from A beta, A delta, and C fibers. Now, dorsal horn receptors are of these types like AMPA, NMDA, GABA A, voltage gated calcium channel, and glycine receptors, which help inhibitory function. Glutamate stimulates AMPA receptor following stimulation of A delta fiber, and substance P is released on prolonged stimulation of NMDA receptor, which is stimulated in turn by the A delta fiber. There is something called ascending system. Once the information comes to spinal cord, that is the dorsal horn, then it ascends up, right? The noxious information is conveyed from the dorsal horn to the brain via several ascending tracts in the spinal cord. The majority of wide WDR neurons and nociceptive specific neurons are conveyed anterolaterally in three pathways: the spinothalamic tract, spino-reticular tract, and spino-mesencephalic tract. The last two are also involved in descending inhibitory control. Now, what is descending control? The dorsal horn receives inputs from the higher centers that modulates the response to nociceptive input. The key transmitter involved are noradrenaline and serotonin, but endogenous opioids are also involved in descending inhibition at a spinal and supraspinal level, as well as descending control from the brainstem. Nociceptive impulses are also attenuated by input of A beta fibers, transmitting basically information on touch, which is the basis for the use of transcutaneous electrical nerve stimulation. But for simply rubbing, even simply rubbing the hurting part also gives relief, right? This is called gate control theory of pain. And on this concept, I have devised a new technique called hypodermic dermatomal needling, because the A beta fibers have got their peripheral ends at the base of the hair follicle just under the skin. If you put a skin needle, small 26 gauge half-inch needle, just under the skin, presumably stimulating the A beta fibers in the dermatome, which is basically a painful dermatome, I have seen excellent results. Not good, excellent results in almost 90 to 95% of the patients, provided I am correct in diagnosis and I am correct in putting the needle in the right dermatomes. Pain modulation, peripheral sensitization. You need to understand this. There are release of inflammatory mediators, bradykinin, histamine, 5-HT, nitric oxide, leukotrienes, prostaglandins, cytokine, growth factors. These create inflammation and create primary hyperalgesia. And once this spread in the surrounding tissue, they cause secondary hyperalgesia. So secondary order specific sodium channels have a significant role in chronic pain states, and they have shown them to become concentrated in the neuron proximal to the site of nerve injury, and they have their role in hyperalgesia and allodynia of chronic pain states. Now you know what is hyperalgesia and allodynia, right? Whenever a mild stimulus gives more pain, it's called hyperalgesia. But whenever a non-painful stimulus gives pain, it is called allodynia. There is something called central sensitization of the dorsal horn. Central sensitization is an increase in the excitability of the dorsal horn so that the dorsal horn cells have a lower threshold and respond to a low intensity stimuli that are not usually painful. It also results in a greater response to suprathreshold response stimuli, thus producing symptom of allodynia and hyperalgesia, which I just explained. Neuropathic pain. Neuropathic pain arises from disease or injury to the nerves from a number of etiologies. It could be ischemic, traumatic, or infectious. Characteristics of neuropathic pain include spontaneous stimulant-independent pain, and pain that is stimulus-dependent, and exhibits allodynia and hyperalgesia. Now, what are the mechanisms? Mechanisms are peripheral and central. These are the list. We'll go step by step. Peripheral mechanisms. Spontaneous ectopic discharge. It has been shown that after a nerve injury, spontaneous firing at the afferent neuron occurs. A and C fibers have been shown to demonstrate oscillatory activity resulting in ectopic firing. Second is altered gene expression. Damaged peripheral sensory neurons undergo voluntary degeneration and lose contact with the peripheral targets and supply the neurotrophic factors. The sensory neurons undergo altered gene expression, the result of which is change in the type and level of neurotransmitter release in the spinal cord. Spared sensory neurons. There is spontaneous increased activity in the spared afferents as well. Involvement of the sympathetic nervous system. Normally, sympathetic nervous system is not involved in pain conduction, but in a chronic state, this can occur. After a peripheral nerve injury, a coupling develops between sympathetic nervous system and a sensory nervous system. Axons involved develop increased alpha receptor and therefore have an exaggerated response to circulatory catecholamines, often leading to unilateral limb pain, edema, vasomotor changes, pseudomotor changes, asymmetries, etc. Collateral sprouting. Sprouting of the fibers from the sensory axon in the skin have also been shown to occur in denervated nerves. Effects of bradykinin. This main plasma kinin, a vasodilator, is involved in hyperalgesia associated with inflammation, and there is a change in expression with binding site within the dorsal root ganglion after the nerve injury. There are certain central mechanisms of neuropathic pain. Wind-up phenomena. The term wind-up describes the altered response of the dorsal horn neurons to repeated input from C fibers. Following brief, repetitive C fiber stimulation, the dorsal horn cells respond in a linear fashion. However, if the stimulus continues, the further C fiber activation produces an amplified response in the dorsal horn to the same intensity stimuli. This phenomenon is mediated by an NMDA receptor, central sensitization. We have learned this, right? Central disinhibition. Central disinhibition results from a loss of modulator control mechanism, which may lead to abnormal excitation of the central neurons. The main inhibitory neurotransmitter is GABA. It has been shown that suppression of this pathway results in allodynia. Within 2 weeks of peripheral nerve injury, GABA receptor level reduces, so it seems that downregulation of GABA is basically responsible for central sensitization. Expansion of receptive field, that is expansion of the new recruitment. While ongoing activation after injury, there is an expansion of receptive field size leading to increased perception of pain, resulting in secondary hyperalgesia. This expansion of the receptive field does not reflect peripheral nerve or peripheral nerve distribution, but spinal cord architecture. It might therefore be confusing from a diagnostic point of view as it transgresses the boundaries imposed by the hardwired model of the CNS. Simple put, you may not have dermatomal pain. Understood? Immediate early gene expression. Immediate changes in the gene expression of the dorsal horn occur in response of A delta and C fiber stimulation. These changes persist for a variable length of time and may contribute to central neuroplasticity. Noxious stimulation mediated by A delta and C fiber produces an immediate change in the expression of certain genes within the dorsal horn. Contribution of glial cells to pain conditions. There is now increasing recognition that neuropathic pain is not only the result of changes in the cells and pathways, but also the glial cells thought to be the not relevant in neuronal function. Now, what are the symptoms of neuropathic pain? Dysesthesia, hyperalgesia, allodynia, hyperpathia, and hypoalgesia. What is dysesthesia? It's an unpleasant abnormal sensation, whether spontaneous or evoked. Hyperalgesia, an increased response to a painful stimulus. Allodynia, pain elicited by normally non-noxious stimulus. Hyperpathia, a painful syndrome characterized by increased reaction to stimulus, especially a repetitive stimulus, such as well as increasing the threshold. Hypoalgesia, diminished pain response in a normally painful stimulus. Now, what is stimulus-dependent pain? Following nerve injury, increased C fiber activity causes central sensitization within the dorsal horn via NMDA. Central sensitization produces three main effects: enlargement of the sensitive field of the dorsal horn neuron, secondary hyperalgesia, increase in response to a suprathreshold stimulus, that is called hyperalgesia, and generation of a response to the subthreshold stimulus, that is allodynia. These phenomena represent stimulus-dependent pain, although the relationship between stimulus and response might be widely varying. Something called sympathetically mediated pain. Following peripheral nerve injury in these patients, both injured and uninjured primary efferent express alpha-2 adrenoceptors on their membranes, so they become sensitive to circulating acetylcholine and noradrenaline release from sympathetic nerve terminals. Now, direct coupling also occurs between sympathetic and peripheral nervous system. This we have learned, right? So this is now sympathetically mediated pain. Now, neuropathic pain symptoms, common pain symptoms, peripheral neuropathy. That can be metabolic or endocrine, toxic, post-infectious, hereditary, and there are few further in the next slide. Metabolic. Many diabetics, especially those with poor blood glucose control level, develop a distal, symmetrical, proximally spreading, and painful sensory neuropathy. Right? Severe pain is often a feature and may be described as burning, aching, and have lightening components to it. It seems that the main cause is demyelination and to a lesser extent axonal degeneration. Hyperglycemia may have a direct effect on the neuropathic pain by altering the pain threshold, the tolerance, and the affecting opioid receptors. Additionally, an asymmetrical proximal predominantly motor neuropathy can occur, especially in older patients with poor glycemic control. Okay, toxic. Well-known neuropathies here include those caused by alcohol, chemotherapy, and AIDS drugs. Post-infectious, post-herpetic neuropathy. Hereditary, Fabry's disease. Malignant, Neuropathic pain is known to have because of the direct tumor invasion and even chemotherapy. Idiopathic trigeminal neuralgia is idiopathic, right? It can be like um, the ISSP says that sudden, unilateral, usually unilateral, severe, brief, stabbing, recurrent pain in the distribution of one or more branches of cranial nerve is trigeminal neuralgia, also called tic doulorex. It can occasionally be secondary to underlying condition like tumor or multiple sclerosis. This is important. That is why we do MRI. MRI, we have to look for tumor, multiple sclerosis, or a vessel overlying the nerve. Vascular. Pain can be arterial, microvascular, or venous. Neuropathy can, in particular, follow venous insufficiency. In every vascular disease, sympathetic changes may develop which contribute to neuropathic component of the ischemic pain. Patient may develop hyperalgesia, dystrophic skin, and muscle atrophy, vasomotor changes. So sympathetic blocks are very good in these conditions. Post-traumatic. Post-traumatic neuropathies are common and can develop after nerve injury. CRPS and RSD. These are basically two types of complex regional pain syndrome where there is a sympathetic involvement, and that is why there is, you see, there are skin changes, then there are color changes, then there is a stiffness, all right, then there is a continuous pain. Pain may not be dermatomal. So this is complex regional pain syndrome. Central, there are certain central neuropathies. Central pain is associated with spinothalamic cortical dysfunction may develop over a length of time and varies widely between individuals regardless of the etiology. Vascular lesion in the brain and spinal cord can produce it. Multiple sclerosis can produce it. Trauma, tumor, infection, they can also produce central neuropathy. So this concludes my topic, pathophysiology of pain. Remember, this is purely theoretical topic, and that is why I did not put much of images, but I went on giving the real details, theoretical details, and it must have been some theoretical experience as well, but it was needed. I tell you, you should read this PPT more and more, and that will make your clinical practice stronger and stronger. Thank you very much. Thanks for watching this video, and may I request you to subscribe this channel for more such videos. If you liked it, share it with your friends, and don't forget to click the like button. Thank you. Thank you very much.